Greetings, everyone. Greetings, greetings, greetings. This is Tanya Abreu with Rethink Your Health. And we are pre-recording what we weren't able to record last week, much to many people's disappointment, which is a conversation with the gentleman I have on by my side here virtually, Dr. John Silver. What has intrigued me and why I have been so excited to have this discussion is there are so very few people in 2022 in our world today that can proudly say, I am a philosopher. I specialize in the history and philosophy of nursing and how it impacts the health of Americans via our healthcare system. So dynamic, so interesting. And today, what I would love to do, and because we have a lot of nurses who listen to us, and then we also have a lot of just the general public who want to figure out how to make their healthcare better, how to make their family healthier, how to access and use the US healthcare system in a time where it just feels broken and sharp and sometimes almost dangerous. So welcome. And I would love to start our conversation, John, with a discussion about how you got to be a philosopher and what does that mean?
Well, since the age of 2, I wanted to be a philosopher. No, I started in healthcare in 74. My first job was a security guard. I worked my way up over the next decade, respiratory therapy, finally, 84, a registered nurse. And I was pretty much just a registered nurse, minding my own business, working in a couple of states, critical care, all those gory units that everybody loves. Ended up in my practice careers through 2005 working emergency rooms. But in the late 90s, I decided to go back and get a bachelor's degree. I thought I should do it. It's my profession. And I met nurses from a lot of different areas coming back, and they had kind of the same complaints they'd had for 20 years. So I started thinking, why can't nursing control its own practice domain? Why are we getting these ratios we're getting in hospitals and, suffering kind of this overload in this system all the time and didn't really have much.
It was just exacerbated by COVID. We have literally tens of thousands of nurses quitting because they don't have control. I have friends that say, I lost patients because I had to listen to things that I knew were wrong. So I understand where you're coming from with that.
And then there were changes in the healthcare system, which I actually, watched as I was practicing in it. So the move from doctor-owned hospitals and doctors having an amazing amount of influence over healthcare because they were admitting the patients, to the corporate takeover of healthcare when they found out how much money could be made out of it. And then that increasing focus of healthcare on profits. And that impacted everything from where resources were put. I mean, we have almost 30% of our country that has very limited, if any, access to healthcare on a wide range of fronts. Mental health. We're seeing the collapse of maternal health care systems, primary care healthcare systems. So it's kind of a complicated story, but at the end of the bachelor's, I started kind of focusing on the politics of things and the political relationship of nursing in facilities to physicians and the administration, and then a broader look at the political relationship of nursing in the United States and its ability to influence how healthcare was being distributed and how people were getting access. And I studied the history of nursing. I looked at what our roots were. And then this kind of
you traveled.
Yeah, well, when I started looking at the question of what's wrong with healthcare and how do we fix it, broadening that scope instead of just nursing, I decided I was going to step out of healthcare and look back at it. So I was very fortunate at the school I was at, the university, had opened up a new program called the Public Intellectual PhD in Comparative Studies, which is a multidisciplinary program, it allowed me to go look at the historical context of everything from democracies to how they related to systems within those democracies, healthcare specifically, up through the 20th century from basically ancient Greece. So I started looking at this issue and I thought, I'm going to look back and see if I can contribute from a philosophical perspective, because we already had a lot of brilliant nurse PhDs and public health PhDs and docs, but nobody had seemed to have been able to tackle this problem. So I thought my first goal as a philosopher was to figure out, what are the goals of a healthcare system? If we don't know what the goals are, how do we know what kind of system, we need and what we should expect? So I developed 7 goals. And I was fortunate enough to be able to travel. I went to South America. I went to Europe twice. I studied healthcare systems directly. Came back, put every coherent model of healthcare I could find on the planet, Asian system, anything that had a coherent model that was working. And I said, okay, which one of you guys meets all these goals? And none of them did meet all 7 goals. Our system didn't meet any of the 7 goals. So I started thinking, when in the United States have we had a problem where something was too important to be just a commodity, but we didn't want to call it a right? And I found the electrical issue in the 20s because electricity was starting to become much more important for everybody than just a little, toy that the rich people enjoyed. And FDR's solution to that was the public utility model that he developed. So I took that model and I put it on the table and I said, okay, let's see what you do. And I found out if I changed 2 of the variables, the public utility model actually works brilliantly. It satisfies all 7 goals.
Okay, I'm going to slow you down because you're a philosopher and you're brilliant. But let me just kind of break this down. So you, in your work and education and teaching and learning, defined from around the world 7 key goals that would make us as Americans healthier people. Can you share those goals with us first?
Sure, and it's an interesting parallel to how this problem was solved if you understand the goals. I call the goals my silos, and you can take each one of these goals right down to the street level and see how it works. So
okay.
The first goal was equitable, targeted, data-driven access appropriate to the community's needs. Well, that sort of makes sense.
So equitable access. We're Americans. We all deserve access to primary health care. Excellent. Okay.
Quality evidence-based care. One of our problems in this country is we have a tremendous amount of time before evidence-based care actually gets into practice. Some people have said 17 years. It's at least a decade a lot of times. So I thought that people should have evidence-based care, and this model will reunite practice arenas with academic centers so that we can move evidence in and out of this system. I thought there should be an equitable, targeted, and evidence-based distribution of resources. Why are we putting all these resources in suburban areas and completely abandoning rural areas and abandoning a lot of inner city areas? And again, if you look at it, it's because of economics. I thought there should be an interdisciplinary practitioner-led administration so that the system is congruent with the values of the people that are providing the care.
Okay, I'm going to stop you there to break it down for lay people.
Sure.
And so we have quality care, which means it has to have research behind it when you do it. We've got equal distribution of resources, which I think everyone understands. Why isn't the inner city receiving the same preventive pediatric care that suburbia? Why are people in the rural parts of America pretty much ignored because there's not enough of them? And then, of course, goal number 4, which I think is a little trickier, is let's not have doctors run hospitals because they only see it from one perspective. It has to be interdisciplinarian. It has to have nurses, as well as physical therapists, as well as physicians, as well as, the community, everybody, to say this is what will make us healthier as Americans. Okay?
Sure.
Like I said, I'm just translating your genius, Dr. Silver.
Thanks. Well, to me, it makes sense. Yeah, this is another issue of realigning the mission of the healthcare systems to the providers who are actually giving the care. So this council that I've talked about, the regional council, I do have it chaired by nursing. And the reason I do that is because nursing is, in my mind, maybe the only discipline within healthcare that has a complete focus on the other person. When you look at our ethics don't involve making sure that we're great and prosperous and famous and all that. It's always taking care of the other, taking care of patients. And that's congruent with our history too, when we started. And then also having an administration of these regional councils and these facilities. All of us are important in the provision of healthcare. Pharmacists, mental health experts, long-term care, EMS. All of us are important in how that healthcare is actually going to be exerted in the community, how those services are going to be community. And we should also have a word in how things are distributed. We should, in fact, be in charge of how things are distributed based on the evidence that we get. So this model will also allow these specialty practices, whether they're dentistry or pharmacy, to maximize their skills too, without this constant focus on scope of practice battles that we keep fighting in the States.
Okay. All right. So we still have number 5. I don't want to distract from these key goals because they really feed into a vision that you have that's phenomenal. Okay. So goal number 5.
Equitable and positive outcomes. If you're going to be engaged in healthcare in the rural community, you should have the same kind of positive outcomes you do if you're in suburbia or in the city. The idea that any group of people deserves lesser care is very un-American.
Wow. Okay.
Goal 6
is what?
Goal 6 is cost efficiency. We don't want to become the money pit we are now. We spend $4 trillion on healthcare in this country. The model I'm proposing would cut that by about 42%.
Sick care.
Yeah.
Right.
And it makes much more sense to devote resources to prevention so that we don't have the train wrecks we're taking care of and the burden of chronic disease, which is about 65% of what we pay for now. And then I thought the last goal was just as important. Is there has to be social accountability of these systems to the communities they serve. And I also put in a mandate for direct public reporting. So that as a health system, we can talk to our communities and say, look, this is what we're seeing. These are the problems we have. How can we work together to solve these problems? Whether it's obesity or gun violence or type 2 diabetes, whatever the issue is, we have to be able to communicate as a system to the communities we're serving.
And I have heard you speak about the 3 major influences currently on healthcare. One being the kind of shift to for-profit and the new for-profit corporations coming in and saying, we can't do things like we used to do, too much fat, too much redundancy. We got to make changes. And they're not always the smartest changes because they don't always know healthcare. The other influence besides the for-profit was, oh my goodness, why am I not remembering? I know it was public health, but the second one was, I'm sorry, remind me of the second.
You're talking within healthcare structures?
Yeah.
So you've got basically 3 ethical systems trying to work within facilities and healthcare in general. So we have that one for-profit silo that's generating profits. I mean, the CEO salaries are outrageous. You've got corporate overhead on top of that. their board of directors on top of that, LLCs on top of all of them. So we're just siphoning up this huge amount of
Yeah,
money. We have medicine, which is still kind of mired in this hubris that they and only they know anything about healthcare. And then they're very protective of themselves. So you have these scope of practice battles going on all over the place. And then you have nursing, which just wants to take care of people. That is our ethical foundation, is the other. It's the patients, it's communities and neighborhoods and state health and national health. That is our.
I'm going to stop you because I love this ethical. The whole look, if you're not in healthcare and you're a patient, rarely do you think about ethics, but you do know this. The doctors seem, and you talk about it as self-protection. It's not blaming doctors. There's a litigious world in the United States. Every doctor is out to protect themselves from losing everything. So you have these ethics of doctors that are self-protective. Sorry, patient, I can't prescribe nutritional therapy for you because I don't know if it's going to work. And if you die, I may lose my house. I mean, I know that's greatly reduced, but as a patient, that's how it feels. The second, however, is we have nursing ethics, which is about compassion, doing for the patient first. And if I can't, like thousands of nurses are doing, I need to leave. I need to do something else because I can't be responsible for the bad health or, God forbid, death of my patients. So you've got this kind of system of ethics that have evolved that are honestly in conflict. And if you have doctor ethics and nurse ethics in conflict, where does that leave the patient? We're collateral. And I think that you're doing some really cool stuff. So I'm going to go back to, we have these 7 goals. I'm just loving this. Do you have a book, Dr. Silver?
No, I'm kind of more along the Socrates line of philosophers. I do a lot of talking, but I don't do a lot of writing. And when I write, it's more like a stream of thought.
Good. Well, we have to do at least a white paper. But having said that, so we've got these 7 goals, and where you are really getting some notation as a pioneer is the ability to talk about public utility system in the United States, which for the most part work. Even the most economically challenged person in rural America has access to gas or electric. So talk to me a little bit about this public health, this public utility model.
Sure. So if you look at these goals, what you kind of get out of this is it is also the goals of public utility systems, right? We don't want electricity in the rural area blinking off 10 hours a day, and then in the rich areas they have perfect electrical service. So these goals kind of align very well with public utilities, but that's not how I found it. How I found it was because of the frustration of looking at, these goals and models and things that weren't fitting. I decided to go back and ask US history, because the essential problem we have in the country is we will not make the discussion or make the decision about whether healthcare is a right or a privilege. If it's a right, that's going to dictate things like the single payer, the national health systems, all that. If it's just a commodity, we're going to leave a lot of people out of the equation because they won't be able to afford it, or we're not going to be willing to put resources in for them. Mm-hmm, mm-hmm. So I asked US history, when we had to have had this problem before. When was something becoming or was too important to leave it just as a commodity, but we weren't willing to call it a right? And I found the issue of electricity, studied that history back through the natural monopoly theory in England to see how it evolved, how it became, spread to the United States, how FDR passed the Public Utility Holding Corporation Act 1935, how the public utility model developed. So I took that public utility model, I put it on the table with the goals, and I said, all right, let's see if you work. And I found out if I changed 2 of the variables, how it's financed and how it's administered, this model takes healthcare right down to the street level in every community. It is completely aligned with the ethics of all of us.
And they make money. Public utilities companies, I know my electric company is getting so much flack because of their profitability, right? So public utility companies can be privately held, just like healthcare can.
Sure. And there's also public utilities are traded on the market. The thing about public utilities is in the 70s, as corporations were kind of exploding and looking up, public utilities started to be corrupted. They were politically corrupted. And in a lot of states, like, for example, you look at what happened in Texas with the winter, with the collapse of their electrical system, California with Enron. You see, these states were trying to make these things kind of profit centers versus their original mission as public utilities. But public utilities that have not, been corrupted work just great. We have lots of them around the country in a lot of states, and they deliver what they say they're going to deliver.
This is, I mean, I haven't really, I mean, I know that's what I titled this podcast, but I'm sure people are listening and saying, oh my God, why hasn't anybody thought of this before? Now, let me ask you this, because I don't know the answer. I'm a fan of something that's on Netflix called The Midwife. And as I've been watching this amazing series, and I'm sad every time it ends, and I think we're on series like 10 or 11, what becomes is the corollary development of the British Health Service. Or I'm not sure if I have the name right, but basically
NHS.
it is about, what is it?
NHS, National Health Service. Yeah.
National Health Service. And it's not about necessarily socialized medicine, but what it's about is equitable access and prevention, vaccination, key pediatric services, maternal and child health. Talk to me a little bit about what you know and how we are either far from that, or how did they get to that?
Well, Bernie Sanders kind of tries to always make this argument that democratic socialism is different than socialism. I actually hate the word socialism because all societies have elements of socialism. We nationally fund a military.
Being a nation is, right?
Right? We nationally fund a military. We've got the VA system. We've got lots of things that as a society.
I never thought of the VA and the military as socialized protection, but it is, right? We have to pay for it.
I mean, we've decided as a society that some things are like really important and all of us should chip in so that all of us can enjoy sort of the benefits of that service, whatever it is. So when some people talk about socialism, they're talking about, like Noriega or Venezuela or Cuba or something, and they react in horror. But nobody sits there and pays their utility bills and starts screaming about socialism and, why should I have to pay this electric bill? So contextually, the word socialism is kind of meaningless, but societies make decisions about things that are important to them. And especially if you think everyone in that society should have access to that. Education.
Like education.
Yeah.
Bad as education can be in some parts of our country, every child has access to something that teaches them to hopefully read, write, and think like an American. Right. This is, okay, my mind is going. Keep going.
Since our founding, we've thought this, that to be a democracy, to have people be able to make quality decisions in their government, they should be educated to a certain point and understand kind of things about the world and how it works, so that when we vote, we can make intelligent decisions as we vote. Mm-hmm. So education was, up through 12th grade is considered free in this country, depending where you go. Well, that's changing periodically. But these are things that we as a society decided were important. I would argue that if you look at healthcare, inevitably what you're going to find is all of us as Americans, or even people that are just living here, have a right to access to healthcare in a sense, because we've certainly learned in COVID how quickly public health can be jeopardized if we're not vigilant about this stuff. So the quantum leap, I think, of thought in this
Exactly. And
model.
that's what COVID did. Our world stops when public health is not accurate. You know, one of the things that you talked about is that we need quality care based on evidence. Oh my gosh, there was no care of COVID based on any evidence, right? It was just all thrown together because we don't honor healthcare as public health. This is amazing to listen to you. So yes, things fell apart. We understand that. I think what we understand, and I'll just say it, is that healthcare is not a priority in this country unless you are middle class or above. And
Well, we kind of
someone,
have a weird system. So we consider kind of healthcare a commodity that you have to be able to afford, even though we do throw some free clinic stuff around until you're going to die, and then all of a sudden healthcare becomes a right. So it doesn't matter if you have insurance. If you're coding, you're brought into an emergency room. You get the full treatment. You're going to be intubated. You're going to be put in ICU. Nobody's going to say, "Hey, you don't have insurance. Sorry, get out of here." So we have this situation where, to get a primary care physician or to get, you mentioned nutrition earlier, you might be surprised. Most doctors have never had a nutrition class.
no,
So they
and they
can't offer
certainly have
that
not had
service.
a functional nutrition class. They know
Right.
not to eat junk food, not to get fat on gross food, but they've never really understood functional nutrition. And I find this also amazing. I mean, you said something about healthcare and public health, and we just have no truly well-funded, right? Because the worst place to end up, I'm sorry, I know friends that went in and got their MPHs and they're making as much as school teachers. They're in county health departments, figuring out the gonorrhea problem. It's awful. Instead of taking public health as our true treasure in this country, so that the crisis and the trillions in loss due to COVID and the million lives practically lost, not to mention all of the loss of just mental health, doesn't happen again. Just simply doesn't happen again.
Well, public health departments in states are subject to the governance of the states. So as states have tried over the last 30 or 40 years to decrease their budgets, a lot of people think of public health departments as just kind of monitoring STDs or something. They don't understand these things. They're just an expense on the budget. And, hey, why are we paying for this? Let's cut it back to the bone. And also we saw in COVID how easily corrupted some of these departments of health can be. Florida is the classic example. Most
Yours
researchers
were both in Florida.
most researchers in Florida can't trust much of anything coming out of the Department of Health in the state. It was completely politicized. People were fired. There were secret committees that oversaw, COVID statistics, deaths related to COVID, because the government in Florida wanted to keep those numbers real down so that they could, later on force this state open. They hid information from people. We didn't know what was going on in nursing homes for months. When they forced the schools open, they wouldn't tell people how many COVID cases were in the school you were sending your kids back to. They put a new surgeon general who's an anti-vaxxer and anti-masker in place. So the system of public health, because it's under the control of state governments, has also been shown to be very politically vulnerable.
Interesting, because I had never thought, I guess I know it's the Department of Public Health of whatever state, but somehow in my naivete, I always think that it's going to be dictated by science. I know that's stupid, but I'm always thinking it's going to be dictated somehow by research, right? And COVID really, and not to get into a COVID discussion here, but showed me that the public health model generally, even like the masking model, that you could go in a restaurant, you had to wear your mask, you sat down, you ate, you talked, you spit, you had everything you wanted to do. But if you had to get up to go to the bathroom, you had to put the mask back on because evidently the COVID vaccine only exists above table level. I mean, the COVID virus only exists. I mean, there was no science.
Well, in their defense, and I will say this, it's called a novo coronavirus. This was a brand new virus that science had really not seen before, in the sense, well, we did see a little bit of it in SARS,
Mhm.
but this was way beyond SARS. This
Okay.
was more aligned with the spread of stuff like measles, than it was like the flu. And I think it took time for scientists to start to really understand this virus, how it moved around in populations. So there were a lot of mixed messages coming out from the science community. But again, science takes time. When something is new, we have to study it and learn how it moves. How do we control this thing? We got the vaccines, but by that time, the whole thing had been politicized to the point where people were refusing to get the vaccinations, and they were
Yeah, because
refusing.
there was just such mixed messages, and I don't want to get into that because I refuse to get anything but J&J. But the issue back to where we are right now is none of this is. I mean, it becomes healthcare is a political hot potato in our country, and now it's an economic hot potato, right? And we have a system that is, covers 200 million, plus Americans on the daily, and we don't know where it's supposed to go. And you mentioned that, of course, if you're dying, you get the very best and the very much most expensive technologies and medical care. And that's costing us trillions of dollars ultimately, because there's not these depoliticized public health departments that are saying, oh my goodness, if we just take corn syrup out of children's diets, we're going to have a reduction of blank percentage of adult diabetes, which is greatly going to reduce blank, blank, blank. So how do we get there? Dr. Silver, how do we get there? How do we as consumers support you and other pioneers that are working to make healthcare a human right in the United States? It's just not lip service.
Well, I don't know if I'd say, well, I guess it would sort of transition healthcare to be a right if the healthcare system had this ethical and moral obligation to deliver services to all Americans. One of the ways healthcare has been absolutely corrupted is how much money it gives into the political process. So and you have to be careful what year you kind of look at data in, because COVID had a severe impact on a lot of fronts economically. But if you look at 2019, just for an example, the top 5 lobbyists in Washington, healthcare related lobbyists, Big Farm and American Hospital Association and this, gave over $100 million into the political system. Now, you have to ask, why are they giving so much money into the political system? And it's because they want to block any kind of legislation that's going to impact them and diminish profits. In the last 3 years, we saw pharma give over $300 million into the political system because Congress was talking about reopening up, I think it was Title 19, and allowing in Part D Medicare, and allowing Medicare to negotiate drug prices. This terrifies pharmaceutical companies, because Medicare is, one of the largest providers in this country. And if it starts being able to negotiate drug prices, you're going to end up with prices like you have in Canada or Europe. And the United States consumes more drugs than any place else in the world by far. We're the hugest consumer market, and we pay the most for their product. So they have a vested interest in protecting that, politically protecting themselves from, having to negotiate these drug prices. This is another advantage of this regional system model I'm talking about, is the regional systems can negotiate. They can negotiate singly, they can negotiate in groups, or they can all get together and negotiate things like medical equipment, CAT scans, pharmaceuticals, all of this cost overhead that we see on healthcare. These regional systems can work together
especially the for-profit. They're doing more and more of that, right? Because, before hospitals relied on government, right? It's funny, the more I think about what you're talking about, it seems like healthcare in the 80s and 90s was much more socialized than it is now, in terms of using that socialized, in terms of government support, in terms of, overpaying and not caring because, you didn't have to watch your revenues.
Well, this was one of the reasons corporations came in knowing or thinking that there was a lot of fat in healthcare. We can get rid of that, convert that into profit for ourselves. But they didn't do it to reduce the cost of healthcare. They did it so they could shift that money over to their own profit centers of corporate overhead, blah, 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 blah.
Right. Right.
And you do that by micromanaging supplies, and you do that by micromanaging personnel.
Mhm.
Because if they could have offshored nurses 30 years ago, they'd have done it. We'd have ended up, working remote videos in India, providing care here, because nursing is the number one overhead in personnel costs as far as employees to healthcare systems.
Hmm.
There were actually movements in the 90s to replace RNs at the bedside with lesser paid, like, EMTs and assistants and stuff. New York City kind of went through that.
And
And
it's
New York,
going on. I mean, yeah, it's
they
happening.
do it if they could, but
Yeah.
the American public wants a registered nurse at that bedside. That's what saved us.
And the American public, I don't know if people who are watching know this, but yes, you may get a registered nurse, but she may be 23 years old with no experience. And there's not a preceptor, a person who is in their 50s or even their 60s. They used to stay because they wanted to teach. They wanted to help the future of nursing. So it's bad out there. I was hospitalized for vertigo, and they were trying to figure it out because there were it was honestly, I will say this, I won't say the name of the hospital, but it was honestly apparent that there was no one of experience, no one that was managing my case or even looking at multiple tests at the same time. And I'm laying there losing time, losing money, and if I were really sick, losing my life. And it made me frightened, Dr. Silver, for the future of this country. And this was a for-profit hospital here in South Florida. Specialists would come in, give their opinion. A hospitalist would change. I was right there over the weekend. So when the new hospitalists came in, they weren't really even interested in what happened 2 days ago. It is insane. And I'm educated. I've been in healthcare 30 plus years, and I felt vulnerable. I just wanted, and I ended up leaving after 5 days.
And that nurse that's taking care of you might also have 6, 7, 8 patients they're trying to manage. And the hospitals make money by throughput. So there's all this pressure on the nurses for discharge and filling beds and admissions and this constant turnover. We kind of toss people. Now they're talking about hospitals at home where, maybe you come in for one day at the hospital and the next thing, who's going to take care of you in your house? It's just.
And a lot of people do not, talking about equitable environments, a lot of people do not have environments that are healthy,
Yeah.
Oh my goodness. Okay, so we're going to move into kind of summation. And first of all, how do people get in touch with you that want to learn more? Do you have a website?
I personally do not, but my group, Nurses Transforming Healthcare.org, does. So you can get in, kind of get a feel of what we're talking about. I work with just a brilliant group of people. Kim Evans from Kentucky, who's a integrative provider, nurse practitioner, who's had her own practice for 20 something years. Kathleen Bartholomew, who's a well-known writer and speaker and a health culture expert. Leanne Myers, who was a podcast host. I think you know Leanne.
Nurse influencer extraordinaire. She told me all about you. So I just want to tell people that's nursestransforminghealthcare.com. I'll put it
.org.
.org. Okay, I'm going to put it in the chat room for everybody. at the moment. Okay, so
By the way, we just put our Declaration of Independence up there. I wrote a Declaration of Independence for nursing,
okay,
which is interesting.
yeah, it's great. It's
And you
great.
can sign it.
So that's on the nursestransforminghealthcare.org site.
I think it
Now,
just
let
went
me
up.
ask you, as we kind of finish our conversation, what do you think, as you know, as a pioneer in this nurses transforming healthcare and this healthcare as a public utility model, what do you think the key next steps are? I mean, there's a big election coming up, right? And to me, it's not about Democrat and Republican, it's about ethics. And it's about who is going to talk my ethics, who is going to talk about education and healthcare as the primary problem. I mean, this is my personal opinion. This is op-ed in the United States, that if your kids aren't healthy, they're not going to learn. And if our kids don't learn, we might as well declare our third world status right now. So
Yeah.
what are the steps?
So we have this model. I also have the community assessment tool we need. And I think we need to start, healthcare is like overwhelmingly nursing care at multiple levels. 95% of healthcare is nursing care. So it made sense to me, instead of doing public health assessments of communities, we should do nursing assessments of communities. So I worked with a model based on Gene Watson's work out of the University of Colorado to do caring nursing assessments of communities, because when people feel cared for, they're going to be more responsive to you and utilize resources. Anyway, so I also had to work out the financial model for this. So I stopped for 2 years my doctorate and got an MBA certification from Tulane, so I could talk intelligently with economists about the economic sustainability model that's needed. So we've got the model, the goals, the community assessment tool, we've got the finance part worked out of it. But how are you going to get this into the political discussion has always been sort of the challenge. If politicians are being paid for, which they are by the, we talked about that 100 million or 300 million a year going into their coffers. And yet it has to be political action that's going to address this change we need in how healthcare is delivered in the country. Well, the only other route you can really take is to go public. And there's no public discussion of this model compared to like Medicare for all or the Obamacare, PPACA legislation. Biden wants to just incrementally change that. Some people, politicians, want to destroy it completely. Medicare for all, I don't think has a chance in this country because it's definitely socialized medicine. And just that word together is going to turn off half this country. This is a model that's uniquely American. The public utility concept is something that we've done in this country that people understand. Like you said, the rural farmer, when he flips that electrical switch and gets power in his house, isn't shaking his fist at the sky screaming, damn socialists. So it's a model we understand. It accomplishes the goals.
And it's a model that's fairly unique to the United States, the public utility model.
Yes, it is. So we can be proud and pat ourselves on the back about that. But healthcare is, in its core, a public utility. It benefits all of us. We all need it. It's completely unpredictable. You don't know when you're going to walk outside and, a tree branch is going to fall and hit your head, or an auto accident, or your 5-year-old's going to develop type 1 diabetes. There's no predictability in a lot of this. So it's not really a commodity like you think of, I budget for my big screen TV and buy it in 6 months. It could happen now. It could happen 10 minutes from now. It could happen a year from now. You have no idea of knowing when you're going to need those services. And that's true of people in every community because we're all human beings. So healthcare at its core is a public utility. Let's just make the system congruent with that philosophy of what healthcare is.
And well, I I know that we'll be hearing more about this, and we'll certainly share when I put this up on various, we have about 8 platforms that we broadcast from. When I put this recorded, I'll definitely put up the Nurses Transforming Healthcare. And I know that you'll be speaking in some various places, but I am absolutely thrilled that we had a chance to record this. As difficult as it has been for me. I can just see me already integrating so much of what we shared today into my own MO as I talk about transformational healthcare personally for people, as well as systematically. Dr. John Silver is on LinkedIn. Please
Can I
follow.
leave?
Yes.
Can I leave everybody with one kind of final thought? The quantum leap in understanding this model is if you can get away from thinking of healthcare as 480 million individual billable interactions between a person and providers. And if you can start thinking of healthcare as services that are delivered to communities, it changes conceptually the understanding of how we can finance this and actually deliver this model into communities.
Yeah.
So I just leave
Yeah.
it.
So it goes from transactional care to community,
Correct.
which is, which is very American, and it's very,
And every
I
community
think,
is a little
practically
different, right?
attainable. Yeah.
Every community is a little different. It's going to be different for farmers and ranchers than it is for inner city people.
Yeah.
The healthcare system has to understand that.
Yeah. Well, thank you again. And LinkedIn is where lots of people can find you and track you and see your writing and your thinking. Once again, I appreciate it. Everyone, thank you for Rethink Your Health. Please share this podcast. Please use hashtag Rethink Your Health. We are growing every single day. We also can be found, and this podcast will live not only on Rethink Your Health YouTube, but on our website. And we'll be starting a newsletter actually now that we have 1,000+ subscribers. So please subscribe. It's www.rethinkyourhealth, RETHINKYOURHEALTH.com. Thank you, everyone. Thank you again, Dr. Silver. And we'll see you next Tuesday when we have our 48th episode with Ken Cushman about polishing your diamond for personal and professional transformation. Thank you very much. Take care. Bye-bye.